the whole day for classification because I pay attention to the fistula classification more than 10 years. But I cannot make any progress. So until recently, 3 years ago, I met with our friend from the Asian Society, maybe a few in there, and a few, and they suggested that we should come out with a new classification. Then I start a little bit serious. And they let me, maybe at the time, you remember? That time, okay. But I think it's time that we start to look at this, to focus at this problem seriously. And this is the start of my work for the fistula classification. If we look at the fistula classification, there are many. The most popular is the Parkes classification. It's 42 years now. There are many others. Sumikoshi is still popular and used in Japan. And Milligan-Morgan 2.0, Shafik 2 complex. Eisenhammer may be the best one, but it's neglected. Eisenhammer. And recently, we have St. James MRI fistula classification. And we have 2 classifications come out last year. So we have many. But when I read all of these classifications, I still have questions. So this is Parkes. I will discuss about Parkes classification because Parkes classification is the most widely used today. And we will widely used for the next decade, at least, maybe 10 or 20 years. And then I think it should fade down. He is a famous surgeon. I will show you why we need a new fistula classification. In fact, Parkes classification have 4 major types. We all know this picture. Type 1, intersphincteric, 45. Type 2, transsphincteric, 30. Type 3, suprasphincteric, 20. Type 4, extrasphincteric, 5%. That is his report. In the 400 cases in 15 years. If we look closely, it's long period of case series in 15 years. Small number of cases. It means that only 2 cases a month. A long period of time, so it's retrospective, difficult to be sure that it is a good correction or not. Because no other report in the world reflects similar result at Parkes. Full scale of Parkes have 14 subtypes, and no one uses it. And illustration of Parkes classification are misleading and harmful. I will tell you why. In fact, Parkes modified his classification from Stelner, from Germany. This is 14 type, and no one knows this. No one uses it. Let's go to the type 1. The type 1 is an intersphincteric type 1. You can see in this picture, you understand. But in the right hand of you, that the intersphincteric, high intersphincteric horseshoe or high intersphincteric superaerator. It's still in the type 1. In the type 1. It's different, but it's still in the type 1. Why? This is first drawback. Let's go to the second. The intersphincteric type, 45%, impossible. Intersphincteric, the true one, the real one, very rare. In my case series, less than 10%, only 5%. Most of the intersphincteric in type 1 of Parkes, in fact, is low transsphincteric. Because it's much more common. Low transsphincteric is the most common. And intersphincteric, the real one, is very rare, very, very rare. Then go to the transsphincteric. In fact, he tried to separate high and low, but no one used it. So I assume that Parkes do not divide the high and low transsphincteric. And this is the major drawback of Parkes classification. Because low transsphincteric is easy to treat, but the high transsphincteric is much more difficult. It should not go into the same classification. This is the major drawback of this classification. Then we go to the next one, the supra and extrasphincteric. In fact, supra 20% of cases impossible. And I know that suprasphincteric always iatrogenic. So why you combine the natural to the iatrogenic? This classification. But in fact, this classification includes everything, includes the other pathology, either trauma, other abdominal sepsis. In this classification, they include everything. The suprasphincteric, extrasphincteric again is iatrogenic. It's not the real one. I will explain. And of course, he draw the picture only 2 dimensions. So the internal opening is in the lateral. You never see a high transsphincteric like this that had an internal opening on the lateral. So this picture is misleading. The on the right hand is the correct one. So this picture is incorrect, and the student misleading for the student and make harm to the patient. I say supra and extrasphincteric part is iatrogenic. This is part comment by himself. He wrote, in case where the fistula were initially thought to be suprasphincteric, there was doubt to its exact track, either because fibrosis prevents adequate access or because unclear charting of the fistula case record. So even he do not know is supra or extra or just infra elevator, low transsphincteric, low issue, Even he himself do not know. The other record, other comment by himself, impossible to be ascertained the location of some fistula. In relation to people like the fibrosis sometimes or obscure the anatomy, that is impossible to be sure to the exact position of epirectalis. In fact, he do not know. And this is his against Park. He's Eisenhammer, South Africa. Maybe he studied from the St. Mark, I think. He said many complex fistula described by Parks result from faulty surgical treatment leading to iatrogenic disease. I agree with him. Totally agree. And this is supported by other authors. In other clinical experience, this one also seemed to confirm Eisenhammer's view of non-existence of supra or extrasphincteric tract of cryptoglandular origin, which primarily loop the external sphincter and the pivorectalis muscle. So we all know that is not correct. Recently, maybe last year, Garg from India, he said that no extrasphincteric fistula were found in recent large MRI-based study. He claimed that he is the biggest report of the supra-elevator abscess. So he said that he never see an extrasphincteric. So he said that extrasphincteric is just over-diagnosis. So if you see any series that has extra and supra, it means that those series is not reliable. I just conclude like this. If you look at the picture of suprasphincteric in the famous textbook, you see the treatment is very strange. If you treat like this, it's sure that you can have incontinence. So the classification make harm to the patient. And if you see the picture like this, how can you see the extrasphincteric? I do not know how to manage this type of patient. But you say that he needs a colostomy over there. But I think with modern understanding, we never need colostomy. Maybe extreme case we need, but I never see one. For the MRI classification, I will stop park here, go to the MRI classification. St. James classification. When the radiologist report, gate 1, gate 2, gate 4, and the surgeon read it, gate 4, what is it? Oh, cannot understand. But because we surgeons do not try to understand them, in fact, we should learn from them too. But if we look closely for the St. James, just look closely. The St. James classification, in fact, is the Park classification. You can see, except some different place for the, let's say, the inter with abscess or inter without abscess, it should intersphincteric. The transsphincteric with abscess is a transsphincteric. The high trans or trans elevator is but he put suprasphincteric here in the St. James. Number 5, super elevator is here. Trans elevator is here. But in Park, high intersphincteric in the Taiwan. That's all different. That's the only difference. So, St. James is still the same as Park and have many drawbacks. And the other classification come out from China, MRI classification, last year. And the other come out from India last year. So it means that many people know that the available classification is not good enough, and they try to make a new one. This is our study to come out with the fistula. I will focus on what happened, what is the natural pattern. I study anatomy, I study MRI and lip finding, and come out with the natural pattern of anal sepsis. Especially the case that never, I have a correction of case that never operated before, and come out with the natural pattern of sepsis. This is the natural fistula abscess, natural abscess, never operated before. But just look at the picture. We have perianal, we have intersphincteric, we have perineal space abscess, we have ischioanal abscess, like this. And when come to the fistula, we have only 5 types. 1 low intersphincteric, 2 low transsphincteric, 3 anterior high trans, 4 posterior high trans, and 5 high intersphincteric. And this is the classification based on the natural sepsis pattern. I press number 5 here because number 5 may occur by its own, or many times is combined with number 4. High transsphincteric to superelevator never occur in anterior or lateral. It can maybe, but unlikely. Extremely rare. Most of the time, the high transsphincteric superelevator occur posteriorly. So I put it here. Every type of this have reason. If we look at the number 4 and number 5, this is the picture. The MRI show that the elevator is intact. And we have infra-elevator abscess and supra-elevator abscess in the same, in this patient. But the elevator is intact. It means that 4 infra-elevator, 5 high intersphincteric is a mix between 4 and 5 classification. We go, just go. I just go. This is, do not need anything. There are 5 patterns of natural anal sepsis. A new classification is needed, and maybe we need international consensus. I think that's the way to go. Okay, we go to the next presentation.
Thank you, Professor Arun. Perhaps we'll hold the questions until after the next speaker. The next speaker is Professor Manuel Francisco Rojas from Philippines, from Medical City. Again, he's no stranger to the colorectal fraternity. He will speak to us this afternoon for Keynote Lecture number 6, a proposed anal sepsis classification.
Good afternoon. I was so excited about coming after Arun and so honored that when I lost my voice last Sunday, I tried everything. Steroids, everything. I wish I had some Indian medicine to use also, but I had to absent myself from the the 2 days we had, just to try to rest my voice, and still nothing happened. But anyway, it is an honor to be here. This is an extension of Professor Arun's talk, and he mentioned we had a preliminary meeting in Bali 3 years ago, and then we had several meetings with other representatives from the ASEAN country. Charles was there, April, I was there, and then more people joined in. Monroy from the Philippines, Kokyan from Singapore, and really we wanted some consensus on how, going of course after Arun's own findings, we could standardize some form of classification for fistulas. And we called ourselves the ASEAN Anal Sepsis Study Group, the AASSG. If you notice, AS is somewhere in that nomenclature somehow. Anyway, I have no disclosures except that many of these slides are from Arun himself, and many of the concepts are from Arun himself. We've talked about how present classification systems are failing or too simple for the cases we see, including the MRI classification by radiology. And I'm very glad Arun worked with the radiologists this last 2 weeks to come up with a fantastic radiology classification, close to what we're presenting today. I noticed also Charles was presenting, if you see in the lower part of his slides, some form of the classification we're trying to propose. In the current era of fistula treatment, whether it's minimally invasive or maximally invasive, there is really a need to better define the course of fistula tracts preoperatively. If you look at many of the papers on lift, recurrence is still an issue. And I think what is lacking is how to understand why these recurrences occur. And to better understand that, and I think when you see patients with recurrences, we really don't know exactly what was done. And we need some reporting to understand what was done so that we can understand what should be done next. So in the classification of anal sepsis, the existing anal fistula classification systems are insufficient in describing the specific details of anal fistula. Most clinical classifications currently in use were devised before the availability of MRI and endoanal ultrasound. As the practice of anal fistula surgery becomes more specialized, requiring expertise and experience, there is a need for experts to standardize and detail reports on classification and surgical technique, particularly for complex cases that flit from surgeon to surgeon. An ideal classification system should be standard and functional, whether for use in MRI or ultrasound or during surgery. It should be able to describe in detail the anal sepsis patterns, facilitate surgical decision-making and operative data recording, as well as prognosticate long-term results of treatment or recurrence. Classification should involve the whole spectrum of anal cryptoglandular infections, acute anal abscesses, chronic or recurrent abscesses, blind sinuses, mature fistula tracts, multiple internal and external openings. Because this happens and can happen, all of them in one patient. And sometimes the textbooks make you think that abscesses are separate from fistulas. Anatomy, of course, is important, and I won't go into the details. That has been discussed very expertly earlier, including where abscesses are likely to occur. We will now go to the patterns or precepts for how we're going to look at this classification. And I have here the legend, the internal opening in red, fistula tract, abscess in green, external opening. Of course, this is mine. You know, we've been working separately. We've only been meeting once or twice a year. So we've made our own modifications along the way, and we do need, and I think I have to stress this is a work in progress. This is a work that we want you to be involved in, all of us in the ASEAN. and it's something we need to keep meeting about. We've had to make sure we are in coordination with radiologists, and so even as many of us prefer to use posterior, at 12 o'clock, we have decided for this classification to use 12 o'clock anterior so that we don't confuse the radiologists. So the first pattern or precept is the internal opening is all, again, we have to thank Arun for these observations. The internal opening is almost always located along the dentate line in any one of the following: posterior midline, 6 o'clock, or 6 o'clock, or and these are our previous drawings. So posterior is up, no, and I'm using here the nomenclature we're proposing. Anterior is either 11 o'clock, 12 o'clock, or 1 o'clock. Number 2, internal openings above the dentate line or through external sphincter bundles are most likely iatrogenic in origin or similar to external openings. The internal opening is almost always, 3 fistula tracts do not break through external anal muscles or bundles, but rather follow anatomic planes between the muscles. And as was shown, you can have the low type between the subcutaneous and the superficial, or the high type between the superficial or the puborectalis, but they don't break through the bundles themselves. Arun has talked about the 5 types: the intersphincteric, the low transsphincteric, the high transsphincteric, and the high transsphincteric straight, and the high transsphincteric anal. Again, this is a summary of that: low, type 1, type 2, type 3, anterior high, type 4, posterior high, tracking through the ischoanal, and type 5, a high intersphincteric type. Supralevator abscesses track upward and from, and therefore should be drained through the intersphincteric space. They don't, and as Arun shown, they should not be breaking through the levators. Now, as for patterns of anterior high transsphincteric fistulas or abscesses, you have these patterns where, again, you can have either an 11, 12, or 1 o'clock opening, and they can either be straight transsphincteric, they can break into the intersphincteric space first, and then go to the external sphincters into the other side or the same side, or very lateral. For posterior high transsphincteric unilateral fistulas, they can break to the deep postanal space and lateral. They can break high and intersphincteric, and then lateral, intersphincteric, and then deep postanal and lateral. You can have different types. To make you understand that more, you can have this type where it breaks into the deep postanal here, and then tracks lateral, breaks into the intersphincteric and tracks up, breaks into the intersphincteric and tracks lateral, breaks both into the intersphincteric and deep postanal and tracks lateral, or breaks into the intersphincteric and then goes immediately lateral. So these are the patterns that Arun has shown. If you're looking at bilateral sphincters, fistulas, they can break into the deep postanal and then both bilateral. They can go bilateral from the intersphincteric, or they can both from the intersphincteric break one side and then deep postanal and break on the other side. So if you're doing a lift, you need to understand all of these possibilities in order to predict where you ligate the track in the intersphincteric group. So the proposed Arun classification, and we decided to call it Arun for obvious reasons, describes specific details of anal fistulas, the internal opening, the intersphincteric space involvement, external sphincter involvement, perianal, ischiorectal spaces, and laterally, external openings. And the checklist is ongoing. We're still working at it. It's a work in progress. Hopefully, we can meet about it. If you want to join us in trying to validate it, you're very welcome to do so. This is the data sheet that we distributed. We look at the internal opening and we use the clock. Again, anterior is 12 o'clock. And posterior is 6. The intersphincteric space, if there's an abscess or none. Transsphincteric space, no, yes, in terms of presence, and then whether it's low or high. Deep post-anal space, no or yes. Anal space, no, yes. Left, right, abscess, no abscess. External opening, no, yes. And then we use the clock again and the distance to the internal opening. Secondary internal openings, if they're present or if they're not. And if they're present, where they are in the clock, and whether they're below the anorectal ring or above the anorectal ring. Very detailed. But this is the only way we're going to understand what the patients actually had prior to surgery. So I'll give an example. This is a 53-year-old male, diabetic, 2-year history of perianal discharge. Look at the pelvic MRI reading, which was done in another hospital. 2 interspheric fistulas with enhancing walls are seen between the 5 and 7, coursing about the 2.5 cm to exit in the 5 position. The combined tract measures 4.2. I think you can understand now the value of the previous MRI lecture you saw earlier. This is the impression, intersphincteric fistula. I don't know where they got this. Really a need to discuss. This is the fistula. My patients are usually in the left lateral. I like it better that way. This is the tract. This is posterior. This is the external opening. And you can see that there have been some previous external openings in the past. So if we were to classify this is the MRI. In the intersphincteric space, and this is the ultrasound. And then this is the tract. And this is the tract. So we would say the internal opening is at 6, ISSN for no abscess, transsphincteric, Y, yes. I'm sorry, this is high, so that's H. Deep post-anal space, yes, or Y, IAS, N. You can see this is the actual patient with hydrogen peroxide, 6 o'clock position, where the hydrogen peroxide exits. And then external opening Y, yes. And because he has several external openings, 5 o'clock, 5:30, 3:30, at 5, 3, and 6 centimeters. Secondary internal opening, no. And so for this patient, and I think you noticed Charles was already using it in his earlier lectures. This would be a type 4, internal opening 6, 6 o'clock, intersphincteric space, no abscess, transsphincteric, yes, high, deep post-anal space, yes, ischoanal space, no, external opening, yes, 5, 5:30, 3:30, at 5, 3, 6 centimeters, secondary internal opening, no. It's a little modified from the initial one that Arun was made a year ago, something we will have to discuss and continue discussing about. Should we put type of surgery? I hadn't put that in. I think we should, rather than just the operative technique. I don't know if it should be, I think we need to discuss whether it should be a simple checklist or it should be a detailed report, depending on how we want to analyze. I asked my fellow to look at CAPA agreement scores, and basically, MRIs in my country are not that well done, as you can see. Ultrasound is not available. The case I showed you didn't have a 3D ultrasound in that hospital. So anyway, there's so many factors to consider in the ASEAN region, but certainly for this small preliminary paper, there is good agreement in MRI, endoanal ultrasound, and surgery in terms of delineating deep postanal space and ischianal space abscess formation. Fair to moderate agreement in the three modalities in describing where the fistula is transfisteric, whether the fistula is transfisteric, and there is good agreement in the three modalities in assessing both internal and external openings, which is obvious. But again, very early, and experience and expertise may be very important factors here. So in summary, there is a need for experts to standardize and detail reports on fistula abscess patterns and surgical techniques, utilizing a combination of pelvic MRI, endoanal ultrasonography, and surgical evaluation, and we still have to work on the standardization of these techniques. We need to classify, prognosticate, and understand the recurrences. The proposed Arun Anal Sepsis Classification, or ASC, by the ASEAN Anal Sepsis Study Group is currently in development. We welcome further recommendations and collaboration from you in the audience. Thank you very much.
Thank you, Remy. Now we will